ratios. Now we have the best for the last. And Dr. AMAR Agarwal, we call him the father of iododialysis and pupilloplasty repair. And be very careful because he is so fast, you blink your eyes and you will miss a step. So, Dr. AMAR Agarwal, sir, please.
Okay. Thank you very much, Dr. Samir and Dr. Priya for this course. So I think Priya has covered very well everything. So let's see, we can take it to the next level now, okay? I thought I'll first talk to you on pinhole pupilloplasty. So let's understand this. What is the principle here? One, we are making the pupil approximately about 1.5 millimeters. When you make it about 1.5 millimeters, what will happen is the peripheral rays of light are blocked. And when the peripheral rays of light are blocked, you'll see automatically the central rays go in and the patient gets an extended depth of focus. That means he will see distance and near without glasses. That's a big advantage. Now look at this patient, the first case I thought I'll show you. This was from the United States of America. The patient had come all the way from Philadelphia, pellucid marginal degeneration. Someone had done a tuck-in lamellar keratoplasty years back. Now the vision was counting finger 1 meter. Patient was not seeing. Now important is always check the holiday pentacam report. Now do you have this laser pointer here? So you see that 3.3 something is there. That shows the HOA of this patient. So whenever you have 0.3 is normal. So anything above 1, please take it significantly. We also just showed you the holiday pinhole device. So that's a very simple device, and I'll just show it to you in a second back again. You can see that was the pinhole device which I'll just show you the pinhole device, important for you to see because it's from Epsilon. And what basically we are doing here is this. You keep this in front of the patient's eye. So if you have a patient of keratoconus or anything like pellucid marginal degeneration, keep it in front of the patient's eye. Ask him which pupil he likes. If he likes, let's say, 1, 1.5, whatever he likes, we will make the pupil of that size. So now when you have seen this holiday pinhole device, we started working on this. This patient needed a 1.5 millimeter pupil. So we are doing the single pass, 4th row pupilloplasty, just like how Dr. Priya and Samir talked to us about. Pass the straight corneal through the clear cornea, come through the side, railroad the 2 from the other side. I've used a 30 gauge needle, you can use a 26 gauge. Bring the loop out, that is a single pass. Pass it 4 times. Now pull on both ends, and now you see what's happening? The pupil repair has started. Now I've done on one side, now you'll do also on the other side. Now you keep on doing as many times as you want till you make that pupil small. Now look at the Purkinje image which I want you to see. That Purkinje image is extremely important. Now look, that Purkinje image is lying over the iris. So the next step what you need is a vitrectomy probe. All your phaco machines have got good vitrectomy probes available. All you need is in your left hand you got fluid, in the right hand you got a vitrectomy probe. Now I'm going to enlarge the pupil a bit so that I will make my pupil about 1.5 millimeters and I will make it bang centered on the Purkinje image P1. Remember this is P1. So there you see now I've made it round. Now let's see whether this Purkinje image is bang centered. Look at that. The P1 is bang centered, and now you know this patient should be pretty good. Once you have done this, now all you need to do is close up this case. Remember this patient has come all the way from the United States. I have only one chance to make this patient all right. I cannot ask the patient to come back to me. So let's see how the patient behaved post-operatively just now, and I'll show that to you in a second. Now you can see the patient pre-op. It was counting finger 1 meter. The HOA was 3.3. Remember the normal is 0.3. Intraoperatively, Purkinje image P1 in the center of the pupil. Post-op day 1, 6, 9 and N6 without glasses. See the advantage. You can see even near without glasses. 1 week post-op, 6, 9, N6 without glasses. So, I thought I'd show you this case, important. The question comes, why is pinhole pupilloplasty working? We understand the broad concepts. Okay, the bigger concept is, if you take the retina has rods and cones. Now understand one thing, these rods are slender. The cones are obese. So if you see Laurel and Hardy, you know the old comic books which they showed about, the rods are like Laurel, they're thin. The cones are obese or fat like Hardy. Now the point here is, why I'm making this point here is, if you take the fovea, and there are 200 times more cones in the fovea compared to the rest of the retina. Now remember one more thing, in the fovea you do not have rods, you have only cones. I told you just now the cones are obese and fat. Think logically, how can 200 times cones fill into that small space? It cannot happen. There's only one way that can happen is, if the cones are becoming thin like rods. In other words, they become very slender. That's the only way it can happen. So they are cones, they are only in the fovea you have cones, but they are shaped like rods. So what happens is, the rays of the light have to hit the center of the cones to get the best effect. And that is what the advantage of the pinhole pupilloplasty is. So if you see, this is the cone. Next to it, on either side, the structure which you are seeing is the Muller cells. When I have a 6 millimeter pupil, the rays of light will also come from the periphery and will hit the Muller cells and get refracted away. But if I have a 1 or 1.5 millimeter pupil, the cone is like slender like a rod. It will go straight in and go straight into the eye. So that is why the pinhole pupilloplasty anatomically is working. Once you have understood this basic principle here of the pinhole pupilloplasty, let's take it to the next level now. Now you see a patient here. Patient has had RK. Patient has got AK also been done. Astigmatic keratotomy also been done. The pupil is fixed and dilated. Now this patient is not seeing. So you have higher HOA. Look at the HOA of this patient. It's 10.9. Remember, I told you the normal is 0.3. So from now onwards, please get into the habit of checking the HOA of all your cases. Astigmatism you see is about nearly 7. Okay? But the important issue here is the HOA 10.9. Look how high it is. So now, what shall we do? We need to make this pupil about 1 millimeter. We check it on the holiday pinhole device. This is what Priya showed us about, where we are going from behind the iris. So this is reverse fourth-row pupilloplasty. And we have to give full credit to Priya for this work done on this with single pass and reverse fourth row. So you see, I'm going now behind the iris, coming in the front. In single pass, I was going right in the front. Now from the other side also, you see, I'm catching it. Look, my needle will go behind the iris and come out. So now what will happen is, the tail or the knot of the iris will go behind the iris, not in front. Where does it make a big difference? I tell you where it makes a difference is in endothelial keratoplasties. When you're doing an endothelial keratoplasty, you don't want the graft to hit the tail or the knot which is protruding anteriorly. So what you do is, if you do a reverse fourth row pupilloplasty, then it will help a lot in such cases. So here you see now, I'm going to show you the same case, coming back to that RK patient. You can see I'm now going to do the simple way fourth row pupilloplasty. The remaining of the fourth row is just like how we show normally in the single pass fourth row. If someone is not doing fourth row pupilloplasty, please move into it. In the audience here, can you tell me, anyone tried fourth row? All of anyone? So some of you have tried. Good. So those who have not tried, please start it. Now you see, I'm going to do the fourth row on the other side. So let's look at the animation again. Take proline needle, pass it through clear cornea, then pass it through iris. From the other side, you have a paracentesis. Remember, you need a paracentesis only on one side. Now you take a 26 or a 30 gauge needle, pass through the paracentesis, through the iris. Now railroad the two. Bring this suture out. Now look, that loop is coming out. This is single pass. Once only I've done. Now remember the number 4. Pass it 4 times. 1, 2, 3, 4. Now pull on this end and pull on the other end of that side and suture it, gets closed. That is simple. Now remember, normally you do 3, 2, 2. Every time you're going in and pulling out, you have chance of damaging the endothelium, damaging the iris, damaging the IOL. In a single pass photo is just once, but 4 times and you're through. Now see, I'm going to do some more single pass photo. What is the principle? Remember, I need to make this pupil about 1 millimeters. So if your HOA is about 5 and below, you will go to about 1.5. I'm saying roughly. If it is 5 and above, please go for a 1 millimeter. If you have the holiday pinhole device, you can get it from Epsilon. I have no financial interest in this. It's very simple. Keep it in front of the patient. Ask him which pupil he likes. By and large, they will like 1 or 1.5 millimeters. Now look, all I do is, now take my vitrectomy probe. This is important. You need a vitrectomy probe. Just make the pupil correct size, correct centered, and close up the case. Let us see how this patient behaved. Look at the patient pre-op, 2/60. Post-op, day 6. Vision is already 6/9. So you see that happiness which you see on those patients is unbelievable because the results are immediate. And that's the big advantage of pinhole pupilloplasty. So now let's move on to the next case which I thought I'll show you. Look at another case. Patient, another case came from the United States. Patient had RK, cataract, and pinhole pupilloplasty was done. From 636, vision improved to 6/9 N6 without glasses. The question comes now on the next topic, which is important, is can I see the fundus? The answer is yes. Through that same eye, this is a fundus photograph, and you can see nearly about more than 160 degrees of fundus you're seeing. So how is it possible? There are scanning laser ophthalmoscopes. You have the Mirante from Nidec, this is what I use, but you have the Optos, you have the Heidelberg, and you have the Zeiss. So you have 4 machines at present in the market which you can catch it. But let's take a theoretical example. Patient 5 years post-op develops a retinal detachment. What do I do? Okay, very simple. Take a YAG laser, shoot, make the pupil large, and you're back to square one. So now, let's look at another case which I thought I'll show you now subsequently. What is the difference between pinhole pupilloplasty and pinhole IOLs? Remember one thing. Pinhole pupilloplasty, I am changing the pinhole size depending on what the patient wants. So it is a personalized pinhole pupilloplasty. Whereas when you use a pinhole IOL, it's fixed. I cannot change it. It's fixed. Now the second problem in the pinhole IOL is the location is fixed. So if I'm operating a patient, okay, and I need to make my pinhole pupil exactly where I want the Purkinje image to, in a pinhole IOL, I cannot. It's just fixed. I just cannot change. So that's one big problem in the pinhole IOL. The third problem in the pinhole IOL is the cost. It's crazy. It's about $800. Okay? This is just a suture cost nothing. But issue is not the money here. The bigger important to me is that location and the size I cannot change. Another big advantage in pinhole pupilloplasty, because I'm bringing that pupil down, my closed angle will become an open angle. Whereas in a pinhole IOL, please remember, a closed angle remains closed angle. I cannot change it. I can change the game by YAG laser. Let's say I made it too small. Theoretical. I made it about 1 and patient needs it bigger. Just take a YAG laser and enlarge it a bit. In a pinhole IOL, again, you can't do it. So that is why, ladies and gentlemen, you'll see many videos of surgeons now explanting pinhole IOLs. Watch carefully. Go to the YouTube, you'll find it. Whereas in a pinhole pupilloplasty, I don't have this problem at all. All I do is, let's say it's small, I will make it a bit large. So if you make a mistake when you're doing your first case, please make it smaller. I can always enlarge it. If you make it 4 millimeters by mistake, then I have to reoperate. Because if the patient needs a 1 or 1.5, I have to reoperate and make it smaller. So look at this patient of keratoconus again. Pre-op, post-op, and look at the fundus picture below. Through that 1 millimeter or 1.5 millimeter pupil. Now look at this picture. This patient came to me from Bangladesh. Slash wound, knife injury, cut. The surgeon in Bangladesh had operated the patient. The vision was just 660. Cataract is there, obviously there. Then I was going to operate the patient. I asked him, what is the HOA of this patient? Now this told me the HOA is about, look at that, 40 astigmatism. Can you believe it? And the HOA was 109. I said, hello, what are you guys talking? 109? Normal is 0.3. I've never seen a case of 109. This is crazy. Can you imagine how badly aberrated that cornea is? If a 0.3 HOA has become 109 HOA, you can think how badly aberrated that cornea is. So now, I started operating this case. Now I said, listen, the suturing is bad, so let me open up the sutures. So I opened up the sutures first, okay? Now I know there's a cataract there, and this is the big mistake I did. I first opened up the sutures. Now I started my rhexis, and I'm going to do my phaco here. So you see now, once I've done my rhexis, I'm doing my hydrodissection. Now I go in for my phaco, and you will see the fastest phaco in the world, because watch what happens. I've just gone. Look on slow motion. Oh, you see that? My whole wound opened. What does it tell you? I should stop operating. You see, I should have not removed the sutures. I could have done that suturing of the cornea after the phaco surgery. But like stupidly, I did that before, and now the whole wound has opened up. So now my whole cataract came out, nucleus came out through the wound. Now anyway, once it's done, I now have to resuture the entire cornea back again. I was going to anyway suture it, no doubt about it. But I should have done that after the phaco, not before. Still is leaking. Still is leaking. So I have to put some more sutures. Once I put in some more sutures, I will then go in and do the IOL implantation. So here you can see I'm putting a 3-piece IOL. I always put 3-piece IOL in such cases. I tell you why. If I get into a trouble and I get a PCR or something happens in the middle, in this case there's no PC rupture. But if it happens, what will happen is I can anyway do a glued IOL. So now let's move on to this case some more. So here you see now I'm going to do pupilloplasty. Normally, ladies and gentlemen, anyone will tell you let's do PK in this case. So the process is like this. You have a case like this, there's suture. Then 2-3 months later, they'll do the cataract or IOL or whatever it is. Then again 3 months later or 6 months later, they'll do a penetrating keratoplasty. The new concept which I'm talking to everyone is, can we avoid a penetrating keratoplasty in such cases by doing a pinhole pupilloplasty? So let's see whether we can do it or not in this case. Now remember, this patient is from Bangladesh, okay? This patient cannot come back. There are visa issues, there are hotel issues, there is monetary issues also for the patient to fly back in. So I have to make this patient all right. It's a young patient, okay? So next step, keep on doing the fourth row pupilloplasty. The advantage in the fourth row is you can do as many times as you want, okay? It's very simple. Once I have done this, then I will take my vitrectomy probe. Now look, I'm taking my vitrectomy probe, clearing a little bit of that hyphema which is present, checking that pupil. I'm going to miss that scar a little bit, just a little bit, so that enough for the pupil to go through. And look at that. That's what I've created there. My Purkinje image should be bang on track there. Now question comes, how did this patient behave? So let's see how this patient behaved. Post-op day 1, 6/12. Look at this patient. Pre-op, post-op day 1, post-op day 3, 6/6 and N8. As I said, the advantage in this, you have extended depth of focus. But look at the HOA. From 109, it has become to 5.2. The astigmatism from about 40 became 10. But please understand, that is because I resutured. Actually, the beauty of the pinhole pupilloplasty is, whatever the HOA is pre and whatever the HOA is post is the same. The astigmatism, I have not changed anything. But what we have done is, we have neutralized it. So, advantage here is, let's say a patient comes to me with 10 diopters, I don't mind. If he's 20, again I don't mind. Because for me, it does not matter. Whatever his astigmatism is, we will anyway neutralize it. We have not changed his astigmatism. We have not changed his HOA. they remain the same pre and post. So this is what I thought I'll first talk to you on, is this thing called pinhole pupilloplasty. I talk to you another topic, because this is important for us to see. Now imagine you get a patient like this. Patient is a pellucid marginal degeneration, and you get cases like this. Now you know what, many people, they'll do a peripheral cut, suture it all, it's a total mess. Important, why am I showing you this? Look at preoperatively, the Purkinje image is decentered already, preoperatively. When the patient is lying on the table for me, the Purkinje image is already decentered. So when I'm seeing this particular holiday pentacam, I'm seeing that thing, and I'm seeing, look at the Purkinje image is quite decentered. The inverted one is P4, don't look at it. One thing remember, these patients, we will make pseudophakic, because one, it neutralizes the spherical aberration, power, whichever it is, becomes 0. Second thing is, I don't want this patient to come to me with a cataract. Third thing is, the astigmatism I will anyway neutralize with the pinhole. So once I have done this, I'll then put my IOL inside. Then I start working on the pupilloplasty. Why am I showing this particular case is to show you I am going to decenter the pinhole a little bit to match my Purkinje image, which is already decentered. If I don't do that slight decentration of the Purkinje image, and I still say, no, I'll stick to the bank center, that patient is not going to be happy. And that is why I'm showing you this case of pellucid marginal degeneration, in which I'm decentering the Purkinje, the pinhole pupil to match my Purkinje image. So you see, I'm going to do some more of this pupilloplasty. You see, I did a vertical, and now I'm doing a horizontal. So depending on the situation, you can do a vertical or a horizontal fourth row pupilloplasty. Once you have done that, I will make it slightly smaller and smaller until it is slightly better off, and I can make my pupil approximately 1 to 1.5 millimeters. Look, it's now approximately, my rough calculation will be about 3. So I need to make it a bit smaller. First you make it smaller. When it becomes too small, you can always take a vitrectomy probe and make it correct. So here you see again, left hand has the fluid inside the eye, right hand has my vitrectomy probe. Now I will make it bank centered. I use the Constellation machine, but you can use any machine of your choice for the vitrectomy to solve this case. Again, now look how nice the patient is looking on table. Let's see how the patient looked post-operatively, and we'll soon realize the pupil is decentered to match the P1 image as I told you about. Close up this case now. See how the patient behaved post-operatively. So this is a case of pellucid marginal degeneration, which I thought I'll show you because it was important for us to analyze and see this particular case. So look at this, post-op day 1. Vision is already 6/9. And that was the HOA of this patient, 3.1. Now I thought I'll show you one more thing, which was very tough case which came to me here, and I'll show you just now. This patient, look what has happened. This patient had had a intact done. Now look at that. The patient has scarring. There is corneal vascularization, high astigmatism. The HOA is about 4.5. Now normally, I've got an opacity. So now what do? Do I take out the intacts? Do I do a penetrating keratoplasty? What do? If I do a PK, that vascularization will definitely make me reject. I said, listen, leave the intact as it is. Don't touch the corneal opacity. Now what am I going to do? Vision is 6/60. You can see the astigmatism is quite high. You can see the HOA is about 4.5 nearly. So what I'm going to do is I'm going to do the phaco obviously because the patient has definite cataract, and we will make a pinhole pupil. So in other words, I am not going to remove the intacts. I'm leaving them as it is. The corneal opacity is there, does not bother me one bit. Okay, the corneal vascularization is there, does not bother me one bit. All I do is now shift to the fourth row pupiloplasty. In other words, I'm going to do the pinhole pupiloplasty. Let's see how this patient behaved now at the end of the day. So here you see, pass through clear cornea one side. From the other side, you have this railroad, the system through the 26 or a 30 gauge needle. I tend to use a 30 gauge needle because it's smaller. but it's sometimes difficult to railroad it. So if you're comfortable with the 26, that's also fair enough. But the principle is simple. Use the fourth-throw pupilloplasty. If you tend to do a cerclage, one, it takes 45 minutes. I'm telling you honestly. Okay? Second thing, when you do a cerclage, you cannot use a vitrectomy probe to correct the pupil the way you want it. This patient was blind as a bat, 660 vision, and you should see the patient the first post-op day. These patients will fall at your feet. One is a simple procedure. You have patients post-PK, pseudo-faking. They don't see. How do you know how much astigmatism you're going to create in them? All of these patients will become absolutely 20/20 vision with N6 vision or J1 vision. So you see, I'm making it smaller and smaller. The advantage in the fourth row is it's a very simple procedure. Anyone can do it. So if you are just moving on to iris repair, first you move on to this technique of fourth row pupilloplasty. It will save life, becoming very, very easy for you. Here you can see I made that pupil a bit slightly slit-like. It will become slit-like because when you're keeping on doing 1-1-1 on either side, then you take the vitrectomy probe and then you make the pupil exactly round and effective the way you want it to be. So you see some more iris repair is being done, and look at the Purkinje image. It's falling on the iris now. Once it's fallen on the iris, now I will take my vitrectomy probe and correct it. Here you can see now, taking it there, using the vitrectomy probe, enlarging the pupil exactly, making it the right size. Approximately 4.5 HUA, I expect to create a 1.5 millimeter pupil. But best is to use the holiday pinhole device, a very simple device which you can easily get in the from Epsilon available here. So you can see once I made that pupil the right size with the vitrectomy probe, as you can see me doing that. Now let's see how the patient behaved post-operatively. I can also switch off the light from outside. I'm using an endometer to see better, as you can see here. Once I made the pupil round and correct size, check whether the location is also on track, and look here, microscopic light is switched off, and you can see the pupil bang centered. Now let's see how the patient behaved post-operatively. Let's see that just now in a second. So here you can see this. The idea is to show you we have moved on to pinhole pupilloplasty not only for astigmatism or high HOA, also for corneal opacities, for corneal scarring, things like that, where things will make a huge difference to these patients. So look at this patient now here. Pre-op 660, you can see how it's looking, Purkinje image bang centered, and post-op day 1, vision has come to 6.9. Now I thought I'll show you another new technique which we just started, and we also got it published. This is called the trifold technique. I'll just show it to you in a second just now. So now problem is this in this technique. What happens if you have a large iris defect like this? When you have a large iris defect like this, about let's say 120 degrees or more, if you try to do the fourth row pupilloplasty, it will just tear. You cannot close it. Then you are going to go to artificial iris or something like that. Look at this. Patient has large iris defect. I'm trying to repair it with fourth row pupilloplasty. See what will happen now. When I try to repair it, and I'm going to suture it, see what's happening on the other side. Iridolysis is forming. So to solve this problem, we suddenly thought of doing a technique called the trifold. As Priya talked to you, we use for iridolysis the trocar-assisted iridolysis repair. Now what we do in this trifold is, we are using the same principle. So let's look at the animation first, then we show the surgery. Take a 25 gauge trocar, fix it on one side. Now you take a double arm Prolene needle, pass it from the trocar through the pillar of the iris. Now the same double arm through the other side. Now all you have to do is pull. When you pull, you see what happened? The iris pillar has got closer. Now I've taken out this trocar, fix the trocar on the other side. Now the same principle. Now look what's happening. The two pillars have become closer to each other. Once they become closer to each other, so this is a threefold technique or a trifold technique. We did one, we did a second, now we'll do the fourth row pupilloplasty because now the two pillars are much closer and you'll be able to suture up this closer. So this is called the tri-fold technique. Here you can see me now bringing this loop out, doing the 4 throws. Once you have done the 4 throws, I pull, case gets completed. So this particular case, as you can see here, had been operated, sent to me with the complication of large thing. I fixed a glued IOL. Now the question comes, how do I repair this iris? So as I showed you, these are from Alcon. You can get these trocars from Alcon. Okay, I use them for a trocar AC maintenance to have fluid in the eye also. But the same trocar, see, it's blue coloration. If it's blue, it's 25 gauge. So I pass it through one side. Once it's inside that eye, the advantage with this trocar is when you're passing the double arm, you not lock onto the corneal tissue. So here you see, once I've passed it there, I'm catching this iris there, passing that same needle through that iris. Now from there, it'll come out through the sclera. So this is the first arm. Remember that. Then, once you have railroaded these two, you can see I've taken a 30 gauge from the other side. I'll railroad the two, bring it out. Now I'll pass the second arm also and do the same thing on the other side, and all you do is pull. Once you have pulled it, you will see that iris pillar coming closer to its partner on the other side, and that is the game plan. Once that defect, which is large, has become smaller, you'll see life has become much easier for us to do the 4th row pupilloplasty. So you can see now, see how close it's become now. Now I suture up this. Now remove that trocar. I'm fixing the trocar on the other side now. Once that's done, you see again, same double arm. You need a double arm Prolene needle. Now look what's happening. You'll see subsequently, in this case, these two pillars have become closer. Now see the distance between the first surgery when we started, and now you compare it to the one you have ended it with. Now, ladies and gentlemen, it becomes obviously clear, once the distance has become smaller, I can easily do a 4th row pupilloplasty. Otherwise, I tell you what, you'll have to have a big problem. This patient will have glare, photophobia and all, or you'll have to fix an artificial iris, things like that. And you can see here, we have done the 4th row pupilloplasty and closing up this case. So basically, when you're doing the trifold, remember, trocar assisted iris on one side, trocar on the other side, and the third trifold is the 4th row pupilloplasty being done. So here you can see, I'm doing the 4th row pupilloplasty, closing it down as many times as you want. Now, if it has become too small, always use your vitrectomy probe to enlarge that pinhole pupil. So you can do some more of this 4th row pupilloplasty to close the peripheral defects also. Call it is yours. It's all in your hand. I've got fluid continuously going on inside the eye. As you can see, the trocar AC maintainer gives me fluid also continuously inside the eye. Once this is done, now I will take my vitrectomy probe and check whether my pupil is right on track or not. And you'll see me doing that just now. You can see that Purkinje image. Again, concentrate on the Purkinje image. See how it is looking. See that I enlarge the pupil enough to get a good enough pupil. Purkinje image bang centered. The other one is inverted, is P4. Remember that. There are 4 Purkinje images. We have P1, which you're seeing, P2, P3, P4. P2 you don't see. You see P3, which will be too large. By and large, you will get confused between P1 and P4. Remember, P4 will be inverted. That's all. Once that's done, I've closed up this case and sealed it down. And you can see how the patient looks at the end of the day. I think we have just few minutes left only. So rather than me talking on any more videos here, I thought I'll first show you now, talk anything to summarize, and we can have question answers for the few minutes left. So by and large, in this course, what have we done? We've tried to show you various techniques. We showed you the 4th row pupilloplasty. We showed you the sewing machine. But to be honest, we used the trocar-assisted iridiolysis. We showed you the 2-fold technique, that is combining the iridiolysis with the 4th row. Remember, when you do an iridiolysis, you fix the iridiolysis, but the pupil will be decentered. So you want to make that pupil back on track, you have to combine the trocar-assisted iridiolysis with the 4th row pupilloplasty. We talked to the pinhole pupilloplasty. We showed you how it can handle also corneal scarring, corneal opacities, things like that. And also at the end, we talked on the trifold technique. I'd like to thank Priya Samir, and all of you for coming early morning for this course. Any questions, please feel free to ask. Yes, please, sir.
I think they were wonderful videos that you showed. I just have one question. In case you need to dilate the pupil, you talked about doing laser for those sutures. So does the suture actually fall into the anterior chamber, and then what happens? I mean, have you had an experience with that?
So what happened is in 2017 JCRS, we published a paper on pupil dilatation after fourth row pupiloplasty. See, you have done pupiloplasty here. You have not done here and here, so it does dilate. So the 1.5, let's say 2 to 3 millimeter pupil will become 4. I'm not saying become 12. It's pretty good enough. When you go to pinhole pupil, my point was, suppose he gets a retinal detachment. Even through 1.5, I can see 168 degrees fundus, so it's not issue. Shoot the iris. All you do is shoot the iris, and you enlarge the pupil. When you shot the pupil, iris, you get a large pupil anyway.
Thank you. I have another question from Priya. The case of SICS that you showed, where you used multiple sutures. So were you using multiple proline sutures for each throw that you took? Were you taking...
you mean you are asking me about the scleral tunnel incision?
Yes.
That was a 10-0 suture.
That was a 10-0 proline,
Yeah, that
is
was
it?
a 10-0 proline
Okay,
suture.
okay,
Yes.
thank you.
Any questions?
Yeah, we are open to questions, please.
Sir, I've never done a fourth row pupilloplasty. How do I start?
Very good question. Very important, I like that question. So how do you start? Very simple. Take a simple case, clear cornea. Take a Proline's needle. I'm telling you frankly, it's very simple. I've got my videos on YouTube. Priya's videos are on YouTube, all of us. So all you do is, I'll talk from there. I'll tell you frankly, it's the easiest technique you can think of learning. You don't do glue dial, I don't mind, but learn this technique. It'll change your life. So you need a glue dial forceps. Take an end opening forceps. You will have them dime a dozen from any company you will get. Right now, Epsilon, or I don't know, Esicos, all of them have it. Pass through the clear cornea. You can do a horizontal, which is easier. Let's take horizontal if you're doing. Pass through clear cornea. Now the iris is there. Catch the iris. Pass it through the iris. Leave it like that. But remember, your eye should be pseudophakic.
Okay.
You will hit the cataract. So if the patient is phakic, make him pseudophakic.
Okay, sir.
Now you leave it there. So the needle is touching the IOL. Correct, no?
Yes, sir.
Agreed? Now you made a paracentesis on one side. Now take a 26 gauge needle. Do like this side so that you're not entering into the cornea, entering into paracentesis. Catch, pass it through the iris. Okay?
Yes.
So you got now needle on one side and the Proline needle on this side. Make them touch. It will Proline needle go into the 26 gauge needle, correct?
Yes, sir.
Pull out the 26 gauge needle. This Proline needle will come out with it. Yes. Anybody having any doubts till now? No. Sure? Have doubt, please stop me. I'm here for all of you. Understand?
Yes,
Pulled it out. So now what has happened? You got a suture which has come out like this.
Yes, sir.
Correct? All you do is now bring a loop out. You have a dialer, you have a chopper. Simple. Take the dialer and chopper and make a loop so that the loop comes to the center of the pupil.
Okay.
Now go into the same end opening forceps.
Okay.
You don't have to spend money on any equipment. Same end opening forceps, catch the loop, bring him out through the paracentesis.
Okay,
Correct?
sir. Yes.
So what did? I got a loop out, suture out. Now I brought one loop out.
Yes, sir.
Correct? There's one needle there, no, cut it. Because you don't want to put it 4 times the needle. That small suture, 1, 2, 3, 4. Same direction. You can't do 1, 2 and then do reverse. You go back to 0 only.
Okay.
Do 4 times. Correct?
Yes, sir.
Any doubts till now, anybody? Sure? Now you got suture here, no? Pull, game over.
I have a suggestion that, doing it before you do in a human eye, because this is not as simple as it looks in the animation and things. Because there is also, when you are venturing into doing this, it is also the direction of the needle. Otherwise, it keeps on swiveling like this. I would advise to take up a wet lab course for learning the
I've already enrolled.
pupilloplasty.
We have
Or
here, by the way, huh?
yeah.
I've enrolled, sir.
And
here
alternate,
in
see,
SST. Yes.
in that, I would suggest just focus on the movement of the needle, how you are manipulating it into the anterior chamber, because then it will be a human eye when you will be doing it. And believe me, if you do not hold that long needle properly, you know, it keeps on swiveling like this, and you might even hit the corneal endothelium, or you might hit the lens or something out there. So these are finer points which you will only learn when you do it
When we
yourself.
practice.
So I think a wet lab course would serve very well. And even if you are not in a wet lab, I would suggest, you know, get an animal
It's
eye
only
or something
practice,
of
I
that,
think.
and you
Practice
have
and
to
practice.
And I tell
Initial.
you one thing, it's not difficult, trust me, all of
And it's not difficult, yes.
Thank you so much, sir. Thank you, ma'am.
Thank you,
sir.
thank
Thank
you
you
so
for
much.
being here.
Thank you, everyone.
One question, please.
Okay.
Do you use straight needle or curved needle?
It's a straight needle.
Straight needle.
Straight 90.
Curved is available, but it's not here.
But do you bend it or not?
No, we don't make it. It's straight.
Thank you.
Yeah. You will need probably a curved needle if you are doing the cerclage. For that, you need a curved needle. That is very beneficial for doing a cerclage. But otherwise, you can use a straight needle.
Okay. Thank you.